Welcome and thank you for joining us today to learn about the recent COVID-19 updates with one of our leaders in the interventional pulmonary care. I would like to take a moment to introduce you to our speaker, Dr. Raul Mendoza, who was born in Mexico City. He attended medical school at Anáhuac University in Mexico City and completed his residency and fellowship at the University of Miami Jackson Memorial Hospital. He developed his interventional pulmonary skills through various courses in the US, Asia, and Europe. And Dr. Mendoza became board certified in interventional pulmonology in 2016. He has resided in Green Bay since 2001, and in which he has held various leadership roles at Aurora Baycare, including teaching medical students through the UW system. He also was a leader in the multi-specialty lung cancer clinic since 2009, as well as the lung nodule clinic since 2011. Dr. Mendoza serves as the medical director of the respiratory therapy program at NWTC as well. He has been married to his wife, Dr. Yolo Diaz, for the past 26 years and has enjoyed raising their two sons together who are now in college. In his free time, he enjoys spending time with family, traveling, and biking all different places around the world. Thank you, Dr. Mendoza, for taking the time to update us all on this important matter. And I will turn it over to you.
Thank you so much. And thank you everyone for putting up with me once again. It's an honor to be talking to the leaders of the business community in Manitowoc and other surrounding areas. And it's incredible that it's another year, and I've been talking to you since last year, and here we are. I just want to do my opening statement. Things are bad, but they are not nearly as bad as we were last year. Yes, they are bad in the sense that we have a lot of community transmission, but we have a lot more tools in our at our disposal. So therefore, we are in a better position, and we play smart. Our community will be safe. I wish it was safer, but there's always different opinions. But despite of what we hear, we're okay. We could do a lot better, and if you listen and carefully and follow science, we're going to be in better position. For the few people that probably did not have a chance to see one of my first presentations, I briefly will go onto the biology of the virus, and I will explain a little bit the mutations. And if I didn't for the sake of time, I will try not to elaborate much. But if I don't cover something at the end, I will have plenty of time for questions and answers. And with that, I will remind you how is the coronavirus. And I'm going to use my mouse just to point at the coronavirus. Corona means in Latin and also in the Spanish crown. And the coronavirus was named precisely coronavirus because it has these spike proteins, which are responsible for creating the crown-like structure around the virus. And this spike protein, it has been the target for monoclonal antibodies and for the production of different vaccines. Also, this protein and then the outer envelope, some of the glycoproteins and the nucleocapsids, they produce some immune response, and those are the areas that are under investigation to see if a universal coronavirus vaccine can be produced, because the areas, the structure changes little by little. Every time the virus gets into a host and replicates and reproduces, there's a new spike protein with just a slight variation, not perfect. And that slight variation over many generations, over many cycles, after it infects another person and another person, then eventually that spike protein, it is not identical or very similar to the previous one. So this virus, and this has been the story for millions of years probably of this virus, it will continue to mutate. So now that we're more educated, we hear about the mutations. This is something that has been happening, and the reason why we have the COVID-19 epidemic in the first place is because of a mutation. So it will continue to mutate, and we are trying to outsmart the virus. But again, the more variable region is the spike protein, and the more stable part of the virus are the others. And right now we have targets against the spike protein, but we have targets, or we're under research trying to see if the other less variable parts of the virus can also be included in a vaccine that will make a stable vaccine that will last for years to come. So the coronavirus have been part of our history. Those annoying common colds that we got every winter, 5 or 10% of the common colds were caused by the coronavirus, and sometimes 30% during outbreaks. Those are alpha and beta coronavirus, and so those, our immune system recognized them. It is nothing more than a common cold. Very, very seldom, only in very immune suppressed people, it can cause pneumonia, but for the most part, it's just an annoying thing. But this one, because it's a novel, it's a new coronavirus, then it has mutated, and our immune system in the upper airway does not recognize it right away, and this virus replicates and goes right away to the lower airway, to the lungs, and that's where it can cause trouble. And so we have had mutations that have passed from the mammals into the humans. So we have in 2001, 2002, we have the SARS. Then in 2009, we have MERS, and now we are in the COVID-19 pandemic. Since the SARS and the MERS, we already have RNA vaccines in development that were tested, but they didn't have enough patients to test the clinical efficacy of these vaccines. So one of the first things that I want to reiterate is that the mRNA vaccine technology has been available since the early 2000s. So this is nothing new. Actually, the technology was there, and that was the main reason why the mRNA vaccines were able to be produced in a record time, because we have already some trials and some opportunities to test this type of vaccines in the previous epidemics that didn't reach pandemic level. And then now we're going to jump. Now that I told you and about why the mutations and the biology of the virus, because this is an update and I have talked to you now, I'm going to talk to you about the numbers. So now so we have different, now the new nomenclature is alpha, beta, gamma, and delta. And then so with the delta, we start seeing, of course, the uptick in cases. This is data from yesterday in Brown County, the last 7 days. And what we can see is that we start seeing the curve going up again of new cases. We start seeing hospital admissions going up again, and the positivity rate. So all these curves are going up. How high this curve will go, I don't have any idea. But around the world, India, in England, in Israel, the curve went up steep, like really fast, peak in about 6 weeks, and then start just going down. So I don't know, and there's a good reason to believe that this delta will follow the same pattern, and we are just at the very first weeks of this surge, if you want to call it. Now, what is different of this surge from the others is that the mortality, yeah, we'll see patients, particularly vaccinated people, dying, which is sad and bad because this is by now almost a preventable disease. But the amount of deaths that we're going to see will be substantially less, mainly because of vaccines, but also because now, a year and a half after the pandemic, we know a lot more about how to treat this. But what is true, the hospital admissions are starting to increase, and we have still the potential to overwhelm our emergency room departments and our ICU as well. In Manitowoc, there is the increase in the positivity, as you can see in the curve here, and also there's an uptick in the hospital admissions. How high this curve in other areas in the South, in Florida, in Alabama, Mississippi, the surge has exceeded already in the hospital admissions or whatever happened in the last year, and this is mostly among unvaccinated people, although because the prevalence of the disease and the transmissibility of the disease is high in some communities, we will see some vaccinated people also getting infected and also making it to the hospital. Substantially less as compared to non-vaccinated people, but yes, you will see, because I will explain to you in more detail, the vaccines are only one of the many tools that we have at our disposal to prevent hospital admissions, but yet it's still possible that a vaccinated person can get disease, although less likely and less severe. And in Manitowoc, unfortunately, we did not reach, not nearly, and I use the past tense because I believe that most of the people who wanted and who were eligible to be vaccinated had the opportunity in the past 6 or 7 months to do that. And most of the people who are electing not to be vaccinated, I think it's enough of wait and see, in my opinion. There's plenty of information and people, they already have a preconceived idea about why they want to be vaccinated or why they don't want to be vaccinated. Every day when I talk to patients, 1 or 2, eventually they agree to receive the vaccine, but I don't think we're going to be able to capture enough people and then for 2 shots and to be able to have herd immunity or have the community super protected. So Manitowoc County, unfortunately, is a vulnerable community when it comes down to transmission from the Delta. One of the virologists from California say that Delta will find unvaccinated people. It's not a matter if, you will find unvaccinated people. So for the population 12 years of age and older, 56% have been vaccinated. For the people of 18 years and older, 59%. The elderly patients, of course, 86%, and it is in Manitowoc. In Brown County, we're doing a little bit better, but not by far. So 61% population 12-year-old, 63 18-year-old and older, and 91% population 65 and older. And this is the latest. And again, this is now, I told you Brown County, I told you Manitowoc County. In Wisconsin at large, we see the cases ramping up. Of course, Milwaukee is leading into one of those areas. Hospital admissions are going up. But as I told you before, even though you see a little bit of uptick of deaths, I still do not see an increase in deaths. We will see people dying. Actually, we just have, unfortunately, a fatality not a few days ago here. But an unvaccinated person, but we will see, but not nearly as bad as we did in the surge in November and December. So this is where we are, and I put the source in case you want to look for reliable sources other than the Wisconsin Health Department. And as I told you, We have an increase in people getting vaccinated all the way till June and then July, but then we're kind of plateauing. Since July, we are plateauing. Now, with the new federal government mandates and the hospital systems mandating vaccines and other big companies mandated vaccines, we are expecting to see about a 10% increase. But all these mandates are going to happen in the next couple of months, and Delta is right here in our face. So I don't think this is going to be able to impact this uptick, this surge. And then this is a little bit about vaccination progress. I think as I told you, the worst of the deaths, and this is before the vaccine was a reality. It happened between November and February and even March, and but now we are just thankfully with less any death. In my opinion, is just a preventable death, and it's sad. But at least the casualties are less and less over time. And I want you to keep that in mind, and we keep on hearing and we get anxious about this. And yes, we have long COVID, and then we have other complications of milder disease. But at least we're not suffering as many casualties. This is a little bit of positive news or better news. Now, frequent question is if we have Delta, and then as in dark blue, and these are the different months, and this is February, March, April, May, June, July, and then I want to see how the share of blue is, which is Delta. So we start seeing a little bit of cases, more cases, more cases, more cases, and now 90% of the cases in our state are Delta. And we have to remember that Delta, because it's not recognized as well by the immune system. That's one. Number two, it has the potential to replicate faster and in the throat when patients are asymptomatic, when patients have no symptoms. So the patient can be completely fine, normal, and unwillingly it's having the viruses replicated at a very fast rate. Billions and billions of copies of the virus are being produced in a matter of 24 hours. And that person unwillingly is shedding virus to the community. And on average, one person infected with Delta will infect 6 people, as opposed to the wild type virus, which happened in the spring of last year. The average was 2.3, 2.5. So this is 2.5 more infectious as compared. That's number one. And because the viral load is a lot more in our body, then that's one of the reasons why people get sicker with the Delta. That's why children were not seen as affected by the wild type viruses or the previous mutations. And now we start hearing about cases of children. We're also hearing cases of children being infected and being symptomatic and being in the hospital because many of the adults are vaccinated, and now many of the younger people are arriving to the hospital with symptoms. So this is where we are in our state with Delta. And as you can see, little by little, we start seeing more and more Deltas as judged by the state lab. Let's talk a little bit about vaccines. So one question is whether those are experimental, and the answer is no, plain and simple. As I told you before, these vaccines have been developed since the early 2000s. The technology for the RNA vaccine, for instance, was given in 1995. We have all the tools since 2001 to create some imperfect mRNA vaccines. They were tested. There was some immunity, but the amount of people that could be tested because the pandemic or the epidemic of the SARS went away, it was not enough to say, okay, yeah, it is effective in real life, other than the lab and other than making. We knew that it produces antibodies, but the production of antibodies does not necessarily translates into protection. We need to test these vaccines in real situations. So the same thing happened in 2009. They tried, but then again, the MERS epidemic went away. And then, but the technology was there and then on the shelves and ready to be used when available. And that's why in February, or the code for the virus was released to the world. And in late February, right away, they used pieces of RNA, they put it together to replicate spike protein, and then in an RNA. And if you know biology from high school, the RNA will never, ever penetrate the DNA, the nuclei, will never. RNA goes into the cytoplasm, which, and then there's a factory, the ribosome will start producing proteins. So the nuclei is in one area, and then RNA will never, ever get to your core, to your DNA, will never mix. So one of the misconceptions and conspiracy theories is that it affects your DNA. No, RNA enters to that RNA factory, and just like a Snapchat, it will produce for a few hours thousands of copies of the spike protein that will be released to the bloodstream, usually the bloodstream in the area of the injection. And then your own immune system will recognize it. What's this? This is something, and it will produce antibodies against that dose. The RNA, just like any other RNA in our body that we have right now, it degrades, it dissolves in a matter of 4 hours. So the vaccine, once enters your cell, it dissolves in a matter of 4 hours, 8 hours, it's gone. But your own enzymes that we produce, and we've been producing for millions of years. So if somebody will test you in few days or few weeks, there will be nothing of that RNA that was injected once upon a time, because it will be gone by your own system. This is the immunity of the vaccine. The natural infection will not only, you will produce billions and billions and billions of viruses for 1 or 2 weeks instead of few hours of the vaccine. And you will not only produce only the spike protein, but you will produce hundreds of other different proteins. And so that, you know, many of them, we don't know what, if they're responsible for strokes or for heart attacks, or they are responsible for other things that we're seeing in the long COVID things. So the natural infection has the potential, I mean, produces damage in your body, even if you have mild symptoms. And the vaccine with RNA, I told you, is like a Snapchat. It goes, you see it, and then it's gone. So the vaccine was initially tested in small groups for the RNA vaccines in April and May. A lot of people went, and then it was given to a lot of people, and then 35,000, 40,000 for the vaccines for 3 or 4 months in real life. And then they compare people that were not vaccinated with vaccinated, and then we just keep on comparing. And then now we have 340 million vaccines given in our country, and billions around the world, and we keep on having data, and that's what I'm going to share with you. So for the Pfizer vaccine, there were 43,000 people over the age of 16, equally male and female. Some of them unwillingly became pregnant, and well, not willingly, unknowingly became pregnant. And then so just because there were thousands of people, and they were able to assess what happened in that pregnancy, and those pregnancies happened without any problem. And patients. Of those 43,000 that were initially tested, many of them after they became pregnant. So there's no miscarriages and there's nothing to that effect. Moderna vaccine was 30,000 people, 18 years old in the United States, and Johnson & Johnson was 43,000 people, many people around the world. That was the initial, that was in the summer of 2021. Now, the efficacy and effectiveness, we have a misconception. So the 95% efficacy does not mean that you will have 95 out of 100 vaccinated will be protected for COVID-19, okay? So what that means is that if you have a group of 100 people, and so 95% of them, they will have no symptoms or very mild symptoms, and then as compared to people who have who have not received the vaccine. So that's why it makes to the news the asymptomatic carriers and people who have been testing twice a week, like in the NFL or in the baseball league, and then it was vaccinated but it's still positive. Yeah, what the vaccine almost guarantees or decreases substantially is that you will not die, and then you will not end up in the hospital if you are fully immunized. That is the fact. You still can have it, and then you still can develop mild symptoms. But when you compare the duration of symptoms of an unvaccinated person to the duration of symptoms of a vaccinated person, of course, is substantially less. The shedding of virus now with Delta, there's substantial difference. People who are infected with Delta shed millions and millions of viruses for many days. And people vaccinated, they shed virus for 2 or 3 days in less quantity because the immune system is at work. And that has to do because the IgA, which is a protein, it is harder to stimulate, or is late to appear in the immune system when it comes down. And IgA is the first line of defense in our nose and in our throat. IgG, it is in our bloodstream and is lower in the lungs. So the IgA is harder to get. They're working on perfecting those vaccines, but we are not there yet. And that's the reason for that. So there is no live virus. So another misconception is that there's live viruses, and then, I don't want to put a live virus in my body. That is a misconception. There are no vaccines using live viruses. And then the adenoviruses, like the Johnson & Johnson, they use a modified version of a different virus. And then the name is the monkey chimpanzee, is a monkey virus that is not affecting the humans. And they use that as a Trojan horse to attach to the cells, and then to use the RNA again in a similar way to the RNA vaccines that don't use a viral vector. And then the COVID, the RNA vaccines is a piece of RNA, only a small piece, not the entire genetic code, just a small piece that has the code for the spike protein, and it has an envelope or a fat particle that will allow for the injection to successfully carry the RNA from the bloodstream into the cells, where it will attach to the cell membrane, and then the RNA will go inside the cell successfully. So the viral vector vaccine, which is the Johnson & Johnson, it cannot give someone COVID-19. And because they have RNA, they do not affect or interact with our DNA in any way. It's just, I don't know why I keep on hearing that, but this is basic biology of high school. And the side effects, is different from adverse effect. A side effect, it is what I have experienced, and probably many of you experience if you have received the vaccine, which is the local soreness and the mild headache or body ache or joint ache that many vaccines produce. And that's your immune system responding and reacting and doing what they are supposed to be doing, and nothing that a Tylenol cannot take care of. And the adverse effect, it's different, which is major, and there is ongoing surveillance for that, and I will be talking about those. I'll talk. So this, I want to put this table. This was published a few days ago in the Morbidity and Mortality Report, which is the newsletter essentially of the CDC, and where they compare just the side effects of the different vaccines in people, in young persons, in people VH. There are different groups, and then so you have the group of 18 to 29, 30 to 49, 50 to 64, and older than 65. So we know and we know exactly how many deaths, how many cases a vaccine in average will prevent. And so here in this column, they put the benefits. So of course, the older you are, the more we are going to prevent. We're going to prevent hospital admissions by the thousands, and we're going to prevent by the thousands also hospital admissions, and we're going to prevent deaths among the different age groups. Now, of course, if you administer this, not only this vaccine, but many other vaccines, polio, rubella, mumps, diphtheria, any, you will have Guillain-Barré and other another type of side effects, adverse effects. And thank God we've been transparent. The medical community, the scientific community, the epidemiologists have been very transparent. And this is the most scrutinized vaccine rollout in the history of humankind. So yes, there are adverse Guillain-Barrés and TTS, which we know how to treat, identify right away and treat right away. But when you put in the relatively rare adverse effects, and then you put in the scale against the potential prevention of cases, hospital admissions, ICU admissions, and deaths, by far, the risks are minimal and the benefits are outweighed there for any age group, including the young population 18 to 29. And this is for females, and for males, the incidence of side effects is less in many ways. And again, the ICU admissions, look at that, 3,300 hospital admissions and 2,300 deaths were prevented in this group that was studied for a period of time. And so the weights are, this is for the Johnson & Johnson. For the Pfizer or the Moderna, the RNA vaccines, the same thing. We prevent numerous deaths, and then we have very, very low incidence of myocarditis, males and females. And again, the benefits to the community, the benefits to the state, the county, the country, the business community, because we don't want people being disabled, are there. And so with relatively adverse consequences. Now, other question is that with the vaccine is less effective. And yes, the vaccine is somewhat less effective. This study published just recently at the New England Journal of Medicine compared the effectiveness according to the vaccine types. and you have the Pfizer vaccine, you have the AstraZeneca. This is the second dose of that, and the AstraZeneca, and this is the Pfizer, which is because this study was done in England. So the efficacy is still there. It's less for the Delta variant, but it's still highly effective. And then in our country, from between March and July, this was before Delta. So the efficacy was sustained in the majority of people, but there was a difference here. After 13 to 24 weeks, in immunocompromised people, people on chemotherapy, people that are on high doses of steroids, people with immune system disorders that are maintaining transplant people, all that person, the efficacy, it wasn't to begin with, it wasn't as good as to other group of people, but a few weeks later, 6 to 8 months later, then we see that it is reaching a 50%, 55% efficacy. And that is one of the many reasons why the CDC issued this week the recommendations for the booster, particularly on this age group. That is the reason, okay? The other reason for why you are hearing about booster vaccinations, this was antibody levels, this is only based on blood testing, and this is doesn't have anything to do, again, antibodies does not equal protection. We have two types of immunity. We have the B cell immunity, which the B cells produce antibodies, and we have the memory immunity, the T cell immunity, where our other type of the T cells, they have some memory and rapidly will recognize, will go to help, and will call again the B cells and say, hey, you remember this? Start producing antibodies. So that is the most effective type of immunity. So the only thing that they for the Moderna vaccine, what they saw is that the antibodies against these different variants decline over time. Okay, so right now, as we speak, based on this study that was published in Science in August 12, based on that, Moderna is working on clinical trials trying to address the question if the lack of antibodies translates into real life lack of efficacy, and they will try to see which type of patients, other than the ones that we know, which are the transplant patients, immune suppressed patients, will qualify the best for booster. But I don't want, the message that I want to convey is that the scientific community is working really hard on this, and soon we will have answers, but there's no reason to panic for the booster vaccines yet. There will be a case, and I'm pretty sure that I will show you something. We will need a booster, and this is the next slide. Many vaccines are at least 3 immunizations. For instance, diphtheria, tetanus, the TTP, Haemophilus influenza, and polio. They require for the kids to get 3 of those. And the reason is when you have a primary, when you receive 2 shots, you will stimulate the B cell immunity, the primary immune response. But when you receive the booster, then you have a long and sustained and more forceful immunity. And so that is the case for the 3 shots for many vaccines. And it's possible that the RNA vaccine, the 2-shot vaccine, will need a booster for that reason. So they are working on that, but this is the model that the immunologists and the experts on vaccine have used on many vaccines. And it seems that the RNA vaccines will not be the exception. And the key is just to know what is the timing what is the dose that is the most effective to boost the immune system the best way possible. We are about to find that those answers. I'm using the we, but no, they are about to find that answer. This is a scientific busy slide, but what I want to show you here is that the NIH, the National Institute of Health, continues to revise the treatment for patients in the hospital. So we know, for instance, that the monoclonal antibodies still work, and the sooner you give them to people that are unvaccinated or who start having symptoms, the better. So if you have in your household or somebody in your business that tests positive and is an unvaccinated person, that person not only should isolate through quarantine, but also should monitor for respiratory symptoms. And if they start having respiratory symptoms and the oxygenation start going down, the best time is the sooner the better. Go to the emergency room to get the monoclonal antibodies. In that way, we can prevent hospital admissions and worsening and death. So it's not 100% effective, but it works better compared to people who do not receive this treatment. For patients who are in the hospital and require oxygen, so dexamethasone, since last year, we know that it helps. Remdesivir, it's been a lot of, it's a mildly effective medication that at best shortens a little bit the hospital stay. But in reality, I don't think it does a lot to save lives. But the sooner you give it for patients, as indicated here, the better. And now we have medications like baricitinib or tocilizumab, which are medications that were used for rheumatoid arthritis. There is a protein that is called IL-6, interleukin-6, which is responsible for a lot of things in our body. When we block the response of that protein, it seems that it reduces substantially the inflammation in the lungs. But this medication is not for everyone. It's only for people who are very sick and who have demonstrated signs and symptoms of worsening respiratory disease. And there are many other indications and highly specialized. I just finished, we just finished on May 30th, one of the nationwide trials for another type of medication. It's called a calcium channel blocker, who blocks the release of interleukin-6 and many other. And we're just waiting, the people, the statisticians are analyzing all the data from the close to 400 patients that we enroll. And we will know soon if this medication was effective to prevent respiratory failure related to COVID or not. We will know in the next few weeks. And so that's what we have for new medications, and that's another reason why we're seeing less people dying, because we have much better medications as compared to last year. I put this slide on my website, but also I want to share with you. They did a survey to send to COVID experts, virologists, epidemiologists, infectious diseases specialists, and they asked them this question last week and say, what will you do in your real life? And then they asked these questions, and I'm just telling you about what they opine, and then you can see the answers there. I think this is interesting, and I think I belong to. I will say no to the first three for sure, and then the others, depending on the circumstances. Don't want to influence, but since you're a business community, I want to show you what transpires in the medical community, and what conversations when the patients ask to them or to us about risks. So we just assess. So indoor is still a high risk, but you know, a single tool will not be responsible for finishing this pandemic. This pandemic will finish with time, you know, and yes, our immune system slowly but surely will adapt to these viruses, but that's going to take, according to the experts, a total of 4 years. That doesn't mean 4 years of disaster. Every time, every new surge will be with less casualties, with less hospital admissions, with less people getting infected, hopefully, or the infections will be milder, just like the common cold. And this COVID-19 will stay with us for the rest of our lives, but eventually will turn into a common cold and another nuisance just like the others. But a vaccine or a booster will not be the only solution. So we still need to continue thinking about masks. And I know that is a pain in the neck and it's a nuisance and it's an inconvenience, but masks is another layer of prevention that will further reduce the shedding of virus to others. Remember, the vast majority of people infecting others right now is people who do not know that they have the infection, but yet they've been in the community spreading the virus. And that is so masks is another, ventilation systems is another, hand washing is another. I mean, by now, I think it's all common sense. And I know how difficult these past 18 months have been for the business community. And I just want to share that I feel, and I know exactly what you've been going through. I don't think lockdowns are next to impossible to occur based on the political circumstances and because we have vaccines in this country, unlike New Zealand, or unlike Taiwan, or unlike Australia. We have the vaccines. Unfortunately, we have not used them the way we're supposed to, because still a substantial portion of the population have not gone for the vaccine. But then masks, indoors, outdoors there shouldn't be a problem, but indoors masks decrease the burden of the disease. Effective ventilation will be another layer. And I think the combination of everything will mitigate, slowly but surely, will transition us to something more normal. And hopefully next year, I will be giving you a talk about the official ending of the pandemic, hopefully. So I will entertain any questions. We still have about 10 minutes. Thank you.
Yes, for anyone that has any questions, you can utilize the chat button on the bottom of your screen or the Q&A button as well, or feel free to just unmute yourself.
I'm gonna unshare my screen so I can see the chat. Oh, there's a chat here. There's a question here. Okay.
Anybody have any questions? I know that was a lot of great information and went through a lot of the prior questions that I would have asked. So it clarified a lot. But if anybody has anything additional, feel free to let us know. Let's see.
I have one question from Carrie Mueller. Hi, Carrie. If you receive the Johnson & Johnson vaccine, should you get the Pfizer or Moderna? We don't know. Let me tell you the official and the non-official response. The official response is no. The Johnson & Johnson, there's no data whatsoever to talk about booster here officially in the United States. I mean, we don't have any data in clinical trials. So right now, as things stand right now, Johnson & Johnson do not require. Now, this is the official. The non-official, there is plenty of data in studies in different parts of the world that where you receive one shot of one kind, like Johnson & Johnson, and then you mix it with another shot of the other kind, you boost your immune system by a lot. Whether that translates again into real life efficacy, we don't know, and that's why right now there's no recommendation, not official recommendation. But there are multiple studies that show that that's the case. You boost your immune system. So I gave you the official and what we know, and probably at some point that will lead to a recommendation of yes, you can mix the second type of vaccine. That will be the question, the answer to that. So will the third shot be, or will be needed again in 8 months after that? LG, I do not know the answer to that. As I show you in one slide, and based on studies from moms and from the kids, once you give the third shot and you stimulate the other type of immunity, it is possible that you will not need more shots, or you will be protected against many mutations for the foreseeable future. But we don't know the answer to that, and I wish I could give you the answer. But as you know by now, science is discovering new things, and the scientists are working really hard trying to bring those answers to you. So right now, the only thing that we know is that a booster is possible in the future. Number one. Number two, the scientists are working on a universal coronavirus vaccine that one shot will be effective against pretty much all the coronaviruses and for a long period of time. What if someone is allergic to the flu shot or other vaccines? What are the options for other forms of protection? That's an excellent question. So the flu shot, the main allergy for flu shot is eggs. Part of the production of the flu shot includes incubation of the virus in eggs. And so people who are truly allergic to eggs, I mean, there are very few that are truly allergic to eggs. Then that's an issue. But other than that, unfortunately, the RNA vaccines, none of them, involve any egg protein. So the production is a completely different process. And then, yes, it is safe to use it in people who have a history of allergies. We all have allergies. I have latex allergy. I have a strong grass allergy. I can sneeze and cough for hours at a time when I get exposed. And if I get latex, I swell up and I need shots. But yet I received the RNA vaccine without any problem. I didn't have any problem whatsoever. And
great, thank you so much for all the questions and for the additional information. I don't see anything else in the chat, or there is one question in the Q&A that says, if someone has both recovered from COVID and has fully been vaccinated, do they have a higher level of protection than someone that was only vaccinated?
The answer is yes. Yes, that person is a superhuman. We know that recovering from the COVID plus at least one shot of the vaccine will boost the immune system several hundred times more than the people like me who never got infected and was vaccinated. And not only that, the variety of immune response, it confers more protection against other type of mutation. On the other hand, people who got infected and with COVID and are not vaccinated, they are at risk for reinfection with the consequences of long COVID and blood clots and other things that can happen. But a previously infected person who goes for the vaccine is the best case scenario. They are human shields that will not allow for the virus to infect them, will not allow for the virus to replicate inside them, and therefore will not be infecting other people. That is the best case scenario. Unfortunately, people who got infected when there were no vaccines, right?
Thank you. Now, we have a few minutes left if anybody has any additional questions. Otherwise, you can always follow up afterwards as well. Otherwise, I think that is it for today. Thank you so much for your time and your information. It was very informative.
Thank you, Lily. And thank you to the business community in Manitowoc, and thank you for listening to this. Thank you, stay safe. Bye now.